Welcome to QS6, Clinical Education and Innovation. At this time, we'd like to invite Dr. Anand Delwar from Boston Children's Hospital to present their paper, Trends in the Use of Surgical Antibiotic Prophylaxis in General Pediatric Surgery. Are we missing the mark for both stewardship and infection prevention?
Thank you for the opportunity to present our work today. Sorry, how do you, what's up? This one?
The green arrow.
Oh, there we go. Thank you. Sorry about that. Appropriate spectrum for surgical antibiotic prophylaxis is essential for antibiotic stewardship and infection prevention. Consensus guidelines have outlined the appropriate spectrum of coverage for surgical antibiotic prophylaxis based on operative procedure. The purpose of the study was to assess compliance with consensus guidelines in the use of antibiotic prophylaxis in pediatric surgery. This was a retrospective cohort study using the Pediatric Health Information System database. The study cohort included children less than 18 years of age who underwent an elective clean procedure with foreign body implantation or clean contaminated procedure. Noncompliance rates and relative burden of noncompliance were calculated for each procedure. Noncompliance was further categorized into undertreatment, defined as narrower coverage than recommended guidelines, and overtreatment, defined as broader coverage than recommended guidelines. 43% of all procedures were noncompliant with current guidelines. 18% of all procedures were associated with undertreatment, with the highest rates of undertreatment associated with central venous catheter insertion, followed by hepatobiliary and colorectal procedures. In contrast, 25% of all procedures were associated with overtreatment, with the highest rates of overtreatment associated with small bowel procedures, followed by colorectal and hepatobiliary procedures. Putting this in the context of prioritization, this figure shows the relative burden of undertreated cases for each procedure on the x-axis and the relative burden of overtreated cases for each procedure on the y-axis. Procedures with the highest relative burden of undertreated cases were colorectal and gastric procedures, and the procedure with by far the highest relative burden of overtreated cases was small bowel procedures. Based on these results, we can conclude that noncompliance with antimicrobial spectrum guidelines for prophylaxis is common in pediatric surgery, with both over and undertreatment being common themes. These results highlight several high-priority conditions where improved compliance is needed to optimize both antibiotic stewardship and infection prevention. Thank you very much, and I'd be happy to take any questions.
This paper is now open for questions. While we're waiting for folks to come to the microphone, I'm curious what your efforts are in improving the non-compliant cases, both the under and the over treatment.
So actually, that's a very good question. So a couple of things that we've noticed within our data that we've collected. So looking at it in a more granular way, we can identify the reasons for under and over treatment for each of these procedures. So for example, for colorectal procedures, by far the highest reason of over treatment is the use of anti-pseudomonal coverage when it was unindicated. And for something like small bowel procedures, it was the use of anaerobic coverage when it was not indicated. The highest reasons for under treatment were really the omission of surgical antibiotic prophylaxis when they were indicated. So looking at these, we can identify the areas that we really need to focus on within our institution and further efforts. Actually, within our institution, we have had educational efforts to improve compliance within clean procedures, and we've been looking at that and had great success with that. So I think our next step is to look at clean contaminated procedures and actually the spectrum of coverage we're using with this granular data and apply the same methods to improve compliance with that.
Thank you.
Thank you very much.
Any other questions?
Our next talk will be cost-effective methods of optimizing antibiotic stewardship in pediatric non-complicated appendicitis, presented by Dr. Angie Cow from the Carolinas Medical Center.
Thank you very much for the opportunity to present our work today. I have no financial disclosures. Inappropriate overutilization of antibiotics contributes to multi-drug resistant infections as well as increased healthcare spending. And significant practice variations in antibiotic regimens for acute appendicitis have recently been reported in the literature, making it an ideal target for antimicrobial stewardship interventions. After observing institutional variability in antibiotic regimens to treat appendicitis, we saw an opportunity for a quality improvement intervention. Prior to our QI project, patients frequently received variable antibiotics in doses, including a high frequency of extended spectrum antibiotics. Additionally, postoperative antibiotics were often given if the duration was not specifically specified. A multidisciplinary team performed a root cause analysis to identify barriers to antibiotic stewardship. A clinical practice guideline was developed based on high-quality evidence and current guidelines, with specific antibiotic regimens and doses with alternatives if patients had penicillin allergies. These were communicated to providers through a standardized EMR-compatible order set and therefore easily integrated into the provider workflow. This also allowed us to ensure that patients received only a single preoperative dose of antibiotics and that antibiotics did not continue into the postoperative period. Our quality improvement intervention targeted all patients with acute appendicitis and was implemented in June 2017. Data was prospectively collected, and patients treated before and after implementation were compared using univariate analysis. After the implementation of our clinical practice guideline, we observed over 90% adherence to the recommended antibiotic regimen, and the use of extended spectrum antibiotics such as ertapenem decreased by 9-fold. Significantly fewer patients were given multiple preoperative doses of antibiotics as well as postoperative doses, and as a result, patients treated after implementation had a significantly decreased pharmaceutical cost per patient. Our study describes a feasible, multidisciplinary, and standardized approach to optimize antibiotic stewardship that can be easily adopted and tailored to other pediatric surgery procedures. Implementation of our clinical practice guidelines significantly minimized provider variation, reducing inappropriate antibiotic prescribing and pharmacy costs. Thank you very much. I'll be happy to take any questions.
I think you answered one of the questions in the talk, but your abstract used ceftriaxone flagell, and your presentation had anceflagell.
Sorry, it should be ceftriaxone flagell.
So I guess one of the things I wonder is, are you using the same antibiotics for perforated appendicitis? And do you think that there's an opportunity to have even better antibiotic stewardship for non-perforated simple appendicitis?
Absolutely. So I should have specified this approach really was specific to non-complicated appendicitis. The next phase is really to translate that to perforated appendicitis.
Just a quick question. Lauren Berman from Nemours in Delaware. How did you treat gangrenous? Was that in the complicated or the uncomplicated category?
So for the purpose of data analysis, we included that in our perforated appendicitis cohort. We just chose to include that in our exclusion criteria just because that was really surgeon-specific and really not standardized.
I guess with the last 20 seconds of the show of hand, how many people are still routinely using Pseudomonas coverage for either perforated or simple appendicitis in the audience with carbapenems or Zosyn? All right. I think we'd get a different answer 3 years ago.
Thank you.
The next paper is Dr. Hills Dunlap from Boston Children's Hospital, entitled Obesity-Related Differences in Management and Outcomes of Children with Appendicitis, Implications for Treatment Delay, Radiation Stewardship, and Infection Prevention.
Thank you for the opportunity to present our work. I have no disclosures. The prevalence of childhood obesity continues to rise despite increasing public awareness and action. The goal of this study was to examine the association of obesity on transfer patterns, outcomes, and resource utilization in children with suspected appendicitis. This was a multi-center retrospective study of 6,034 children undergoing appendectomy at 29 hospitals participating in NSQIP Pediatric. Obesity was defined as BMI greater than the 95th percentile by age and sex. The presence and severity of appendicitis was established by review of operative reports. Multivariable logistic regression was used to examine the association between obesity and study measures, adjusting for demographic factors, disease severity, and hospital-level random effects. The association of obesity on hospital transfer, preoperative imaging, and perioperative efficiency measures is presented here. Obesity was associated with a significantly increased odds of having been transferred to a NSQIP hospital for definitive care. a higher odds of CT utilization, a lower odds of ultrasound utilization, and longer case duration. The association of obesity on clinical outcomes and resource utilization is presented here. Obesity was associated with a significantly increased odds of overall 30-day complications and a trend towards increased odds of both incisional and organ space SSI. No differences were found between obese and non-obese children for the other measures. In conclusion, obesity is associated with differences in care and outcomes in children with suspected appendicitis, which may have implications for treatment delay, radiation exposure, and infection prevention. Future efforts should explore the drivers of hospital transfer, encourage the utilization and optimization of ultrasound technique, and investigate the nature of SSIs in obese children. Thank you for your attention.
Obviously, a driver for the increased CT scans in these patients, I think, is the more difficult ultrasound results. I'm curious if y'all have developed any protocols to improve ultrasound or an abbreviated MRI protocol for those that are getting preoperative imaging in them.
That's a great question and very relevant. In our institution, we definitely do have new protocols with ultrasound mandated before any further cross-sectional imaging with an expedited MRI protocol being implemented. I think in general the literature is definitely mixed. There are studies that show that in obese children ultrasound is less specific and less sensitive than in non-obese children. However, there are studies that do show that there are equivalence, sensitivity and specificity. So much so that the American College of Radiology continues to recommend ultrasound prior to any CT imaging for both obese and non-obese children. So I really do think that continuing to develop and optimize ultrasound technique and at least utilize that non-invasive study prior to CT or further cross-sectional imaging is warranted.
Thank you.
Thank you.
All right, we'll move on. Dr. Brittany Johnson from Baylor and Texas Children is going to be presenting quantifying the effect of resident education on patient costs and outcomes in pediatric appendicitis.
Thank you for the honor of the podium, and we have no disclosures. Resident involvement in appendectomies has been associated with prolonged hospital stay and longer operative times. Our purpose in this study was to evaluate the effect of resident involvement on appendicitis management. So in our hospital system, we have a main hospital where we have faculty and residents, and we also have a community hospital where we have faculty and APPs. This provides us an opportunity to really evaluate the effect of resident involvement on patient outcomes. So we completed a retrospective chart review over a 2-year time span, including patients with appendectomies. We've enlisted our exclusion criteria here. We collected data on appendicitis severity, operative time, postoperative length of stay, and postoperative course. We had approximately 1,600 patients in our cohort, and demographics between the main hospital and the community hospital are almost identical. We defined operative time from incision start to incision close, and we defined postoperative length of stay from end of the surgery to time to discharge. We found that in simple appendicitis, both operative time and postoperative length of stay were longer when residents were involved at the main campus. And looking at a complex appendicitis, we found that only operative time was longer. It's important to note that between the main hospital and the community hospital, our rate of perforated appendicitis was the same. We additionally looked at readmission rate, which there was no difference, intra-abdominal abscess, also no difference, and emergency room visits, again, no differences between resident cases with resident involvement and those without. Our last analysis was looking at charges data for cases where residents were involved versus those where they were not. We determined charges based on the operative time using standardized cost accounting information at our institution. We found that in both simple and complex appendicitis, charges were higher when residents were involved in the operation. So in conclusion, we found that resident involvement is associated with longer operative time, increased operative charges, and longer postoperative length of stay for simple appendicitis, but there were no differences in outcome. So resident involvement in appendicitis care is safe and effective and necessary for surgery training. Future studies or future directions may include improving resident efficiency to decrease operative times. Thank you, and I'll take any questions.
As always, the number of appendectomies done at TCH is staggering, but to be able to accumulate this kind of volume in such a short period of time.
Yes.
I guess my question is mostly focusing on the length of stay for simple appendicitis and the difference between the two groups. Is that a relationship with resident being involved or a lack of a protocol for same-day discharge in the teaching hospital?
So that is an excellent question, and it is the latter. There is a difference in our main hospital and our community hospital in kind of somewhat of the logistics. We've initiated an early discharge protocol at the hospital, but what happens is that at the main hospital, those patients tend to be operated on later in the day. So they miss the window of being able to discharge compared to the patients at the community hospital. So there may not be an association with the residents, actually. It's just a difference in the logistics at the main hospital versus the community hospital.
Any more questions? All right, thank you so much.
Thank you.
The next paper will be presented by Dr. Pearson from Sunrise Children's Hospital on children's surgical verification, development of a quality and safety tool to evaluate pediatric surgical care and teach the surgical quality process.
Thank you. Children's surgery verification is a quality project by the American College of Surgeons that defines the optimal resources for pediatric surgical care. The green. Which one is it? The green? Okay. Our hospital is Sunrise Children's. It's a 692-bed adult and children's hospital based in downtown Las Vegas. And we provide the full spectrum of pediatric surgical care, including pediatric and neonatal ECMO. One of the requirements of CSV is recording perioperative events, shown here in the Appendix 2. And our challenge is, how do we record this for every child receiving an anesthetic? We identified barriers to addressing the Appendix 2 requirement, including poor EHR, and since our IT department was unable to come up with a computer-based solution for us, we generated a paper-based recording system for this problem. Our document is something that we call the blue sheet, and it records our pre-operative briefing, the timeout, and the debriefing. And it's seen many revisions throughout the years, but our current one has all of this data in addition to intraoperative and postoperative events to 30 days. In our most recent version, we left an area for our quality project stickers so that these patients can be easily identified and included in our smaller projects. We follow every child for the adverse postoperative events at day of surgery and 48 hours and 30 days, and we record this on the blue sheet, which is then updated in an electronic database. Ultimately, having this system has allowed us to increase our visibility, leading to a team atmosphere of quality improvement and review of data in real time. Thank you, and I'd like to answer any questions.
Hi, Stephen Lee from Los Angeles. That's a great solution to a very common problem that we've come across. My question is, who's actually collecting the data at 48 hours and 30 days? Because that seems quite labor intensive.
Absolutely. So if the children are still on our floors, then the paper is collected by one of our team members who goes to the floor and grabs the sheets. If the children have left the hospital since then, we call them up on the phone.
But who's we? Do you have a program managers doing it, a nurse?
Both.
You have that. And then what's the compliance rate? Are you getting 100% capture?
So it is a problem that is not just with our system. A lot of times we have patients who provide the wrong phone numbers, and we are looking into contacting the doctor's offices for their follow-up information as well.
Thank you, and nice work.
Thank you.
All right. For our next talk, we will have, Dr. Anthony Ferrantella from University of Miami present complications while awaiting elective inguinal hernia repair in infants, not as common as you thought.
All right. Good morning, and thank you for the opportunity to present. Okay. Oh, thank you. Several institutions have published their retrospective data and reported that the occurrence of complications in infants awaiting inguinal hernia repair is significant, and that preterm infants are at the higher risk of incarceration, with the most feared complication being strangulation leading to ischemia of the bowel, testicle, or ovary. These studies have led to the common practice of repairing inguinal hernias as soon as feasible in infants, and published surveys of APSA members have demonstrated that most of them prefer to perform hernia repair during the birth hospitalization for infants born prematurely. Here, we aim to understand the true frequency of complications in infants discharged without undergoing repair of a known inguinal hernia. To do this, we utilize the nationwide readmission database, which is part of the Healthcare Cost and Utilization Project, and it's uniquely able to track patients across hospitalizations at different hospitals, the results of which are then weighted for national estimates. From 2010 to 2014, we included all patients under 1 year old with any diagnosis for inguinal hernia, and then excluded those that had their inguinal hernia repaired during the index admission when the hernia was diagnosed. The primary outcome measured was non-elective readmission for any reason up to 1 year later. We identified over 33,000 infants with inguinal hernia, of which just under half underwent hernia repair during the index admission. We then compared those that did or did not undergo hernia repair during that hospital stay. The majority of infants were males in both groups. Exactly 50% were preterm infants, and despite the preferred practice reported by most pediatric surgeons, we observed that preterm infants were less likely than full-term infants to undergo inguinal hernia repair, with only 40% of these infants undergoing surgery prior to discharge. This discrepancy could not be accounted for by the preterm infants that died prior to discharge, as only 2% of those patients in this group had died during that index hospitalization. The majority of all infants identified in the study were treated at large, non-for-profit metropolitan teaching hospitals. We next focused on the cohort that did not undergo hernia repair, and after excluding all of the patients that did not survive, we followed the remaining 17,000 infants for all non-elective readmissions for any reason whatsoever. This likely overestimates the true readmission rates for inguinal hernia-related problems, as many of these children surely required readmission for other reasons. Nonetheless, we observed that only 9 to 10% of infants required readmission within 30 days, and only 15% up to 1 year later. Now, to better understand which patients were truly readmitted due to a problem related to their untreated inguinal hernia, we looked at how many patients actually underwent inguinal hernia during that readmission, since we assumed that any patient admitted for an incarcerated hernia would require prompt surgical repair. And surprisingly, only 1 to 2% of patients originally discharged without inguinal hernia repair went on to require a non-elective repair. We then took a closer look at these patients that underwent urgent hernia repair during the unplanned readmission, and we again saw that most were male, and preterm infants were more likely to have the diagnosis of incarceration with bowel obstruction. But again, these percentages are based on just that 1 to 2% of patients that required urgent hernia repair. None of the infants underwent other procedures indicative of inguinal hernia-related complications, such as bowel resection, orchiectomy, or oophorectomy. There were no deaths during any of these readmissions, and the median time to readmission was actually longer for the preterm compared to the full-term infants. However, the median length of stay for the preterm infants was much longer than what would be expected for recovery after an inguinal hernia repair, suggesting that many of these patients may have been readmitted for other comorbid conditions and simply underwent hernia repair out of convenience. In addition to the limitations common to any large administrative database, our study lacks long-term follow-up since the database only captures readmissions that occur during the same calendar year. Additionally, it does not track readmissions across state lines, which is estimated to occur about 5% of the time. So in conclusion, we've shown that readmissions for infants discharged with an untreated inguinal hernia is less common than prior reports, and true complications necessitating an emergent inguinal hernia repair is substantially less common, perhaps as low as 1 to 2%. And lastly, the occurrence of significant morbidity as a result of that delayed inguinal hernia repair is quite rare, as we didn't identify a single case suggestive of strangulated hernia among this very large sample. So our data would suggest that inguinal hernias, even in preterm infants, can be safely planned as an elective outpatient procedure. Thank you. I'd be happy to take any questions.
Thank you. In the interest of time, we'll move to the next paper.
Thank you.
I'd like to invite Dr. Arnold from the Carolinas Medical Center to present their paper entitled Laparoscopic Assisted versus Open VP Shunt Placement in Children, an Outcome Study Using the ACS NISQUIT Pediatric Database.
Thank you for the opportunity to present. VP shunt placement is one of the most common treatments for hydrocephalus in children. However, VP shunts have a failure rate of up to 40%, and reoperation is frequently required to revise the intraperitoneal portion of the shunt. Historically, shunt placement has been performed via mini laparotomy, but our institution has recently adopted a practice of laparoscopic assisted placement of the intraperitoneal portion of the shunt performed by pediatric surgeons. We sought to examine the outcomes of laparoscopic assisted versus open VP shunt placement using the NISQUIP Pediatric Targeted CSF Shunt Database from 2016 and 17. Patients were divided into two groups, laparoscopic and open. 30-day outcomes were compared between the two groups. 2,370 patients underwent VP shunt placement during the study period. Patient demographics were similar, however, operative times were longer in the laparoscopic group. More children in the open group were undergoing first-time shunt placement. The average total hospital length of stay was significantly shorter in the laparoscopic group, and the time from operation to discharge was also shorter in the laparoscopic group. Unplanned interventions were more than doubled in the open group, and these more often required externalization of the distal portion of the shunt. There was no significant difference in reoperation or readmissions in 30 days. The overall surgical site infection rate, including superficial, deep, and organ space infections, was similar between the two groups. Laparoscopic VP shunt placement appears to be superior to open shunt placement, with patients demonstrating a decrease in total length of stay, decreased postoperative length of stay, and fewer unplanned interventions. Pediatric surgeons working as co-surgeons may improve patient outcomes and reduce resource utilization. Thank you.
I really enjoyed your study, Michael. This is likely information that's not available given the inherent limitations based on the database study, but I'm curious if you have any insight into why so many of these cases are still being opened and how y'all decided at your hospital to transition to a laparoscopic model where y'all assist on all the cases.
Yes, sir. So we have our own institutional data. Our numbers are too small to show as many interventions, but our operative times are actually half compared to our open. And the way our institution made the transition is that essentially a new cohort of pediatric neurosurgeons joined the practice, and they preferred to have the pediatric surgeons perform the intra-abdominal access for them. And our open cohort was from a more senior, now retired surgeon who performed all of his intraperitoneal shunt placements via the laparotomy, and that's how we did our institutional comparison.
Thank you.
Thank you.
Next, we'll call up Hagar Delshad from Boston Children's, who's going to present Improving Resource Utilization and Outcomes Using a Minimally Invasive Pilonidal Protocol.
Good morning. Thank you for allowing us to present our work today. Our team has no disclosures to report. As we know, pilonidal disease is associated with significant morbidity and a prolonged treatment course. At last year's APSA meeting, the Outcomes and Evidence-Based Practice Committee presented us with their best practices for treatment of pilonidal disease, recommending that patients should be treated with incision and drainage for acute abscess, followed by sinusectomy or other forms of minimally invasive pilonidal treatment for excision of pilonidal pits. Flaps and other wide resection methods were to be used only for recalcitrant disease. At Boston Children's, a dedicated pilonidal clinic was started in 2014, and a minimally invasive pilonidal protocol was implemented in 2016. Patients are treated according to this protocol with shaving and home care with improved hygiene until inflammation and drainage subsides, and then had outpatient sinusectomy and a series of laser epilation treatments if hirsute, until asymptomatic and all pits were resolved. For this study, we compared 34 patients with moderate to severe disease using the minimally invasive protocol to 17 patients who were randomly selected after being billed as having surgical excision prior to the clinic's inception. For charge calculation, we included the number of outpatient visits, OR, surgeon, and anesthesia time and charges, facility fees, and number of epilation treatments, if any. We excluded charges for inpatient stays, visiting nurse fees, wound care, and lost work and school time. Outcomes were asymptomatic disease at last known follow-up. In our analysis, there were no significant differences between groups in age, BMI, number of visits, but the MIP group had more males. The excision group had an average of 1.6 operations, lasting an average of 144 minutes in the operating room. The MIP group had 1.4 sinusectomy procedures each, mostly under local. A few patients required anesthesia for procedural anxiety and had a mean of 9 OR minutes per patient. When looking at the charges, the excision group had $29,000 in charges and only 18% were asymptomatic at last known follow-up, while the minimally invasive group had $8,400 in charges and 82% were asymptomatic at last follow-up. These differences were both statistically significant. So we conclude that a minimally invasive protocol, which encompasses laser epilation and outpatient sinusectomy, would improve outcome and reduce discharges for pilonidal disease. Thank you. Happy to take any questions.
It's a nice study, and obviously I'm biased towards minimally invasive pilonidal surgery. I wonder, are the surgical excisions, what I don't understand, are they historical controls, or are there members of the group that aren't part of the pilonidal center in Boston? And has everybody switched over in your institution? And the second question I have is, do you at your institution feel as though there's any equipoise to studying these minimally invasive techniques against these open excisions or flap closures in a prospective manner?
Thank you for that question. So these are historical controls. We only included patients prior to 2014 before the clinic existed. And we included data from our billing system, and any of the surgeons in our group were included. I believe we had about 12 surgeons out of the 20-something that were represented in this group. And obviously some of those patients had more than one operation, so it could have been they were included twice. In terms of course, we'd love to study patients prospectively. However, I'm not sure with the outcomes that we're seeing with minimally invasive care that it would be appropriate to subject the patients to wide excision, especially given the APSA guidelines. But perhaps a multi-center study would be more appropriate.
Any other questions? Thank you.
Thank you.
The next paper would be presented by Dr. Kalis from the Cohen Children's Medical Center at Northwell Health, entitled Pilonidal Pit and Sinus Excision with Trephination and Curettage in Adolescents and Young Adults.
Thank you for allowing me to present my work. We have no disclosures. Pilonidal disease is an inflammatory condition affecting the skin and subcutaneous tissue in the gluteal cleft. And surgical approaches, as we know, typically involve long hospitalizations with long periods of time out of school and work. Novel, less invasive approaches may allow for reduced morbidity but acceptable recurrence rates. One such approach is pilonidal pit and sinus excision with trephination and curettage. In this study, we examine our initial experience utilizing this approach in our tertiary care children's hospital. For those unfamiliar with this technique, it utilizes trephines to excise pits and debride the underlying tracts. It can be done under local anesthesia alone when appropriate, and the trephines are left open and do not require any packing or drains applied. Patients can be discharged home after a short observation period and are allowed to continue their normal activities immediately upon discharge. In order to examine our experience, we conducted a retrospective review of all patients undergoing surgery for pilonidal disease from 2016 to 2018 and considered only those patients undergoing pit and sinus excision. We then contacted those patients via a phone survey to assess their satisfaction with the procedure. In our patient cohort, average age was 17.8 years, and 60% of our patients were male. 100% of our patients were allowed to return home on the same day of the procedure. Our average surgical time was 12.5 minutes and ranged from 3 minutes to 42 minutes. Average pain scores ranged from 0 to 4.5, with an overall average of 0.25. 89% of patients reported no pain at all while in the postoperative care unit, and 94% of patients required no narcotic while in the postoperative care unit. Our average follow-up time was 13 months. During that time, 29.5% of patients had mild recurrence of symptoms, and 13.2% of patients required repeat excision. We conducted a phone survey to assess satisfaction and had a 25% response rate. Nearly 60% of patients reported returning to work or school in 3 or fewer days. 82% of patients reported no use of narcotics while at home. And using a 5-point Likert scale to assess satisfaction, on average, patients reported near perfect scores for their satisfaction with their cosmetic result, as well as their satisfaction with the overall surgical experience. Ultimately, 97% of patients said they would refer this surgery to a friend or family member with pilonidal disease. Therefore, we have shown that this approach to pilonidal disease has low morbidity, acceptable recurrence rates, and is well liked by our patients, and is now our procedure of choice at our institution. And we are now looking at this in a more prospective manner through a multi-center PEDS SRC protocol, for which we are the lead institution. Thank you, and I'll take any questions.
Hello. Peter Liebert from New York. What I'd like to know is how, with this technique, you can deal with the persistent draining sinus that some of these patients have, and some of them more than one persistent draining sinus.
So this technique is not meant to rid the patient of their pilonidal disease, but to create an environment where the patient can heal this on their own. So we see this as a technique that can be utilized multiple times if needed, because it's such a quick procedure, there's such low morbidity, and as the previous presentation showed, it's such reduced cost that we see this as something that can be implemented on a recurrent basis before we see that the patient has failed and move to more invasive approaches.
And may I ask a second question? Why? Sure. What was it that made it more than 13 months for healing?
That wasn't healing time. It was just the average follow-up time that we were able to follow our patients.
How long did it take to heal?
Sorry?
How long did they take to heal?
We didn't look at that in our study, the average healing time.
Ian Mitchell from San Antonio. I had one question. What do you do when they're infected?
The acute infection. So we can use this in patients presenting acutely, depending on what the clinical scenario looks like. Obviously, in really inflamed situations, it's tough to identify the pits and really get a good sense of what needs to be cleaned out. So in those cases, we still would use an incision and drainage, but there are surgeons in our group that use this even in the acute setting.
All right, we'll have to move on now. This session is dedicated to Dr. Alexander Bill, APSA's 7th president of APSA, and the video was prepared by Dr. Yan Shi.
certain malformations of the rectum and anus that are not uncommon, quite common in children, in which there will appear to be no opening at the proper place. And I began to see, as I sketched these things out and saw them back in Boston, that there was a kind of a progression of these lesions, that if you checked them all out, diagrammed, there appear to be a definite progress in the relationship of the lesions. And so any congenital abnormality really is some failure of a normal process.
First of all, describe perhaps a little bit more of how Dr. Coe persuaded you, if you needed to be persuaded, to come here.
Aspects, but the plain fact was it was quite clear that he was a highly respected member of the medical establishment here in this Pacific Northwest, and in fact nationally. So that, and also in particular in the Children's Hospital here. So the opportunity to serve as his junior associate was clearly a very great advantage.
What have been the most rewarding or the high points of your career in connection with the Children's Hospital? What's been giving you the most satisfaction?
To see this thing grow the way it's grown, and yet to maintain, to see the main important aspects of the patient care maintained the way it has been. At the same time, to see the staff be strengthened, and yet those all important functions remain in place. And I come back in here all the time, look around and see how people are doing. And I must say I'm pleased with how they're doing.
All right, we'll move on with Dr. Harbaugh from Nationwide Children's in Columbus, presenting trainee autonomy in the operating room. What do parents know, and what do they want to know?
Thank you for the opportunity to present this work. I'm actually at Michigan.
Sorry about that.
But we worked with Columbus. We have no disclosures. Graduated autonomy is necessary for trainees to develop adequate surgical experience before transition to independent faculty practice. But little information is often shared with the caregivers of children on how trainees are actually involved in the operating room. And so with this study, we sought to understand what caregivers know, want to know, and need to know in order to provide informed consent for trainee involvement in pediatric operations. To do this, we performed a pilot survey of 100 caregivers at 2 academic children's hospitals in 2018. The survey encompassed 3 domains: knowledge of provider roles, willingness to provide consent, varying cases by complexity, by level of trainee autonomy, and by how the trainee was trained, and caregiver opinions, looking at desire and expectations for consent, as well as positive and negative perceptions of trainees. First, for knowledge, here you can see the responses with the text indicating the correct response for each provider role. As you can see, less than half of caregivers could correctly identify the role of attendings, fellows, and residents. The most could correctly identify a medical student. For willingness to consent, these graphs will show the percent of caregivers who responded yes to fellow involvement in a routine procedure. In a traditional time-based training model, you can see that as autonomy increased, willingness to consent decreased. For example, 95% of caregivers responded yes to the fellow assisting the attending surgeon with a routine procedure, whereas 25% responded yes to the fellow operating independently with the attending available to assist but not present in the hospital building. Here you can see a fellow in a competency-based model. Caregivers were more willing to consent across the board to a fellow trained in a competency-based model, though this was significant only for a fellow performing the procedure alone with an attending in the room. Same patterns were seen for complex procedures, but with lower overall rates of consent as expected. Lastly, caregiver opinions reveal tension. 82% desired to give permission for trainee involvement in their child's care, but few had actually understood what a fellow role meant. Next, 80% thought doctors should have more increasing responsibility as they progress through training, but they were less likely to consent to greater trainee autonomy. Opportunities were also revealed.
Caregivers overall had a positive perception of trainee involvement in their child's care. Only 18% had indicated they would not want trainees involved. And explanation of competency-based models also seemed to be reassuring. Future work will focus on creation of discussion aids so that there can become a balance between informed consent process and trainee autonomy in the operating room. Thank you. We'll take any questions.
You should be commended for taking on such a challenging problem or issue that is part of our jobs. I may be a little bit skewed as a New York surgeon, but I'm shocked, and I wonder how you guys feel about the 1 in 4 parents being comfortable with trainees operating on children without the attending in the building. And to me, that seems that's a very high number. Mm-hmm. I would think that would be close to 0%.
Yeah. That's a really interesting point, and I wonder if one part of that is when we looked at knowledge of provider roles, the most common incorrect response for fellow was thinking that a fellow was fully completed with surgical training. We did inform them of what the different roles meant before we asked them about willingness to consent, but I do wonder if some of that lack of knowledge carried over into their responses.
And would you propose that the future of our field is going to be one in where we clearly have to delineate to our parents who will be scrubbed and what their general responsibilities might be in the operating room?
Yeah, I think that's a great question. I read this one great paper that compares consent process for surgery to when you're flying a plane and understanding who's landing that plane. And to myself, I think, if I'm on the plane and the co-pilot or the pilot's going to land the plane for the first time, I honestly don't want to know. I just want to land on the ground safely. And I think that's where we have to really understand how much transparency parents want versus how much they just want to know that their child's going to get out of there okay. Thank you.
Thank you. The next paper will be presented by Dr. Ramos Gonzalez from Boston Children's Hospital, entitled A Novel Combined Cautery Suction Device, the First Product of a Surgical Device Innovation Fellowship.
Good morning. Thank you for the opportunity to present our work. Here are our disclosures. The Surgical Innovation Fellowship is designed to create future surgical entrepreneurs. A multidisciplinary team of mentors guides fellows through the process of ideation and innovation across digital healthcare and medical device development pathways. Available internal and external courses were identified and curated to establish a formal innovation education curriculum that exposes naive fellows to all the phases of innovation and provides the necessary tools to take a project from need to commercial solution. The surgical field is often crowded with retractors, dissectors, cautery, and suction. The repeated exchange between the cautery and suction into the field, which can be both time-consuming and frustrating, was identified as a clinical need. Thus, we set out to develop a novel surgical device that can rapidly toggle between these modalities. A single-use combined cautery suction device was created in which the suction tip can be deployed and retracted with the push of a button. The mechanism for this deployable suction tip is powered by standard operating room suction and activated by the red button seen on these diagrams. Initial designs were developed using SolidWorks, and subsequent rapid prototyping was done using 3D printing. Functional and ergonomic prototypes were later created in partnership with MythWise, a medical device development company. Here, our functional prototype being used in a post-euthanasia porcine model. In the retracted position, the suction tip is proximal to the cautery tip, allowing for an unimpeded use of the cautery, yet remaining active as a smoke evacuator. In the deployed position, the suction tip is mechanically locked in place beyond the cautery tip to allow for both fluid suction and blood dissection capabilities. In conclusion, our hospital-based SIF may be a powerful and useful model to train surgeons, surgical residents to sufficiently navigate the surgical device development pathway. A PCT patent application for our combined cautery suction device was recently filed. I would like to thank all my co-authors and those who paved the way for the Surgical Innovation Fellowship and helped in the development of its first device. Thank you.
This is a fascinating device that I'm sure will have a lot of clinical utility. I know it's very preliminary at this point, but I'm curious if you have any ideas what the cost would be versus a standard Bovie setup.
Yeah, so right now, as you can see in the video, we are in the middle of trying to merge our functional prototype with our industrial prototype. and that would really be the deciding factor in how much it's going to cost. The actual smoke evacuators that we often use in our hospitals are usually around $30, whereas the usual Bobby goes for $2. Our target point is to have a device that we can try to manufacture and sell for around $10 and make it easy and accessible for not only big hospitals but also community centers trying to make a larger sample size that might use our device.
Thank you.
All right, moving on to the next, Dr. Lau is going to be presenting sprayable, biodegradable, intrinsically adhesive, and antimicrobial wound dressing.
Thank you all very much for this opportunity to present. Our study is funded from an NIH R01 as well as our institutional internal funding from Sheikh Zayed. So the current wound environment is that there's no one dressing that's great for wounds of all sizes and shapes. They're often expensive and difficult to apply. So our approach with this is with solution blow spinning, where a solution of biocompatible polymer is blown through an airbrush. The solvent evaporates, allowing for direct deposition of the polymer onto the wound bed. As it comes up to body temperature, it becomes intrinsically adhesive. So the polymer is made up of polylactic co-glycolic acid, which is essentially similar to Vicryl, and polyethylene glycol. You spray it on once, leave it alone, and let the wound heal, and the dressing will fall off. And we were able to add in antimicrobial properties with silver ion as well. So does it work? We tested this in a feasibility porcine model where we made partial thickness wounds on the back skin and randomized the wounds to be dressed with Tegaderm or our polymeric dressing with and without silver, and followed the wounds for 35 days. Looking at these wounds at the end of the experiment, we really couldn't find significant differences in terms of more erythema or more scar tissue at the end of the experiment. Histologically, we looked at the total epidermal and dermal thicknesses at both 7 and 35 days, and we did not find statistically significant differences comparing between the groups. However, if you were to compare it with normal uninjured skin, we found that Tegaderm had a statistically significant thicker epidermis. And we also looked at the critical genes of wound healing by real-time PCR, and we found no statistically significant differences between the three different wound groups or dressing groups. However, we noted that the Tegaderm dressings just did not stay on well. Our polymer dressings stayed on much better, required much fewer dressing replacements within the first 14 days. So in conclusion, we have a dressing that's easy to apply, it's biocompatible with antimicrobial properties and good healing outcomes, and most importantly, it really stays on the wound well. Thank you.
Hi, quick question about your wound care protocol here. So how does this do for deeper wounds, or is it meant really for superficial wounds? And the other part of my question is, how does it do with absorption of exudate? Because it seems like these are superficial wounds that perhaps aren't draining that much. And by comparing it with just the use of Tegaderm alone, it doesn't seem like there's a lot of drainage coming out of the wounds you tested.
Yeah, so these were partial thickness wounds that we made at about 0.6 millimeters. We did not have an opportunity yet to do full thickness wounds. In terms of exudates, our dressing has some absorbent properties, but not fully. And the way that our dressings work is that you spray it on, it can allow drainage to drain outside a wound, around of the wound, but still stay onto the wound bed. Whereas the Tegaderm wounds, it collects the exudates. And I think that is one of the contributing factors as to why it would fall off so quickly, too.
Thank you.
Hello, Peter Liebert, New York. I just wondered how it compares with the old standard pediatric surgical collodion dressing.
I don't know the answer to that because we only did it or did a comparison with Tegaderm, but I think the ability to apply a wound dressing with just a spray without the difficulty of having to wrap all these dressings on and reapply, I think the benefits for the patient and for our care providers is significant.
The benefit of collodion, for those who haven't used it, is you just swab it on, it dries, it falls off by itself.
Thank you.
All right, thank you.
Next paper will be presented by Dr. Snyder from Children's Mercy Hospital, entitled Answering the Questions, Early Results from APSA's Expert Program.
Good morning. The Professional Development Committee would like to present some interim data on the results to date from the Expert Self-Assessment Program. We have no disclosures. The program began roughly 10 years ago and has gone through several iterations. This is the current schema with the different types of self-assessment tests shown. There are now 21 of the pediatric surgery self-assessment PSAP tests, each of which has 60 to 70 questions. There are questions derived from the articles of interest, or so-called e-blasts, from the APSA committees. There are custom courses and the weekly Sunday-spaced learning that many of you are familiar with, which can be done over brunch with an open book and or Bloody Mary. There have been 650 unique users who answered 976 questions, and each of these were attempted a minimum of 10 times. There were over 100,000 first attempts. There's a little bit of divergence between the abstract and the current up-to-date data. 100,000 first attempts to answer the questions, 62% of which were correct on the first try. On the right is a view the system provides us of a single example question, and the donut graph shown breaks down which answer people chose, with green being the correct answer in this case. 88% got it right on this sample question. So I'll now violate every principle of public speaking and fly through the results, with really the goal of making you aware of what data is generated rather than to dwell on the specific details. On the left is a histogram of the percent correct answers, which are color-coded by the 15 major NAT categories. And on the right is a tree map display with the size of each category, or rectangle, proportionate to the number of question attempts, with the more popular topics having a bigger box. This is just a box plot by major category, shown in the vertical lines at the bottom. Again, there were 15 major categories and 192 subcategories. And this briefly may not be seen well as the 10 subcategories with the highest percentage of correct answers on the left side, and on the right are the bottom 10 or least correctly answered subcategories. So in summary, this has several limitations. Only about half of the APSA membership has answered the questions. The quality of the questions can be variable, and they're unevenly distributed by topic. Some have had, some small number of questions may have had many attempts to answer them, and that may skew the results. But on the right are listed the benefits, which are significant and include the ability to identify knowledge gaps, to provide a formative learning tool, to provide spaced repetition, and to be an outlet for rapid dissemination of new information. Future possibilities include individually tailored questions. Thank you for allowing us to present our results. I'd be happy to take any questions.
This is a great tool that I use weekly, and I'd encourage others to use. I'm curious if there's any current plans to expand the program or place any additional focuses on the largest knowledge gaps like oncology.
Yeah, there's lots of directions we plan to take. One of the things I mentioned was individually tailoring it. So if an individual person, the system can tell what questions you're weak on and what you're strong on and avoid asking you those. Other things are testing certain types of questions, for instance, before the annual meeting on topics that are covered in the meeting, and then post-testing afterwards to see how effective the learning was from the meeting. So there's a lot of areas we're exploring.
Oh, we have a question over there.
I must say that I use this and I look forward every Monday like I look forward to coffee for my test. But correct me if I'm wrong. Are you reporting automatically to the American Board of Surgery this activity on behalf of the people who take?
No. No, Dr. Arca has been on our committee for a long time, and so there's some coordination, but we certainly aren't reporting anything to them. We're attempting to collaborate with them to help identify topics of interest that they can make the MOC questions out of, but there's it does not go on your permanent record.
It would be feasible to do that, to save us one step?
I doubt that it would be too feasible to do that, but I suppose it's possible. Thank you.
Thank you. Thank you. All right, we'll move on to our last talk of the session. Thank you all so much for attending the session and participating. This will be given by Dr. Janice Taylor, Increasing Acceptance of Internet-Based Educational Programs by Pediatric Surgeons. Looks like there's an updated title.
The mouse, the advancer, or
the green arrow.
Green arrow. Okay, thank you. Good morning. Last of the session, but first in your hearts, I'm sure. Oh, this is not it. This is for the
That's
session.
why there's a different title.
Yeah. Didn't even see that one I got up here.
So, do you have another presentation by the same presenters?
It's Q84.
There it is. Yeah. Nope, that's not it. That. Nope.
Aaron, while we're waiting, let me respond to one of the questions from the last questioner. As Chuck presented, we collect a lot of data on you all, whether you like it or not. And some of those graphs were pretty intimidating about how much we know about you all.
That's not it either.
Whether you like it or not. The fact of the matter is we do share population-based data with the board about practice gaps and things like that. But in view of the current climate about sharing individual data, I thought it's important to say APSA will never, ever, ever share your individual data with anybody, including the American Board of Surgery.
It was like titled Internet Teaching with, can't remember the title now. Nope. Well, I can just talk about the results. So on behalf of the Professional Development Committee as well, this is a review of the follow-up assessment that we did for expert and NET that were based on the time out from which NET and expert have been implemented as we know them at this point. So NET has been in place for 3 years and expert in place for 6 years. And so given that, it was appropriate time for a follow-up assessment. Last spring, you may remember that you were sent a survey. We got 24% results back, or respondents back. What the survey reviewed and asked about to the APSA membership was practice patterns, how one obtained and accessed their medical knowledge, and self-perceived knowledge gaps. As I said, there were 24% respondents out of a total of 1,215 surveys that were sent out. 43% of these individuals were in academic practice with the pediatric surgery training program. Overall, the top 3 preferred areas of knowledge acquisition were meetings like this, annual meetings, about 27% of individuals. 24% of individuals preferred expert, 24%, and then 20% preferred the NAT. This is in comparison to a 2014 needs assessment with about a similar number of respondents where electronic programs were less desirable overall. 16% of those individuals who responded preferred the electronic programs over the 20 and 24% that preferred NET and expert now. Cost was cited by over 1/3 of those who did not subscribe to NET and expert for the reasons why they didn't do it. And there was no statistically significant difference between expert and NET use regarding payment method or the reason for not subscribing. Over half the respondents always read the discussion in Expert, regardless of whether or not their answer was correct. And although the reference links were evidence-based, these links were rarely followed. When we asked respondents about their self-perceived knowledge gaps, 30% stated that fetal therapy was what they perceived as self-perceived knowledge gap, and over 86% stated they would still subscribe to APSA resources even if there was no CME requirement. So in conclusion, these are well-utilized resources. Certainly it seems that internet resources, electronic learning platforms are more preferred than they were at least about 5 years ago when the last assessment was done. And certainly there is room for improvement and development regarding availability, accessibility, and self-perceived knowledge gaps. Thank you. Happy to take any questions.
So first off, I'd like to commend you for maintaining your composure with without your slides in the background. That's not easy to do.
As I was telling Pramod yesterday, we both forgot our unitards for our interpretive dance performance part of the performance. So I'm sorry.
So I guess my question is, I mean, this is amazing, and the work that's being done by so many APSA members, with Dr. Powell's work and Dr. Snyder's work, we know all about, and the amount of digital information we have to learn how to be better pediatric surgeons is tremendous. And one of the focuses, which is a nice way to end a session, and we're at a conference, is the attack on the conference as a place to come and learn because of financial and inconvenience. So I wonder what you imagine the future of our national conferences where we get together and learn and socialize. And
I think if you, from the numbers, just if you remember them, these national conferences are still the most preferred way of getting that updated information. I think there's also the benefits that especially the trainees and junior faculty can glean from these big meetings and networking and the one-on-one with committee meetings and development of programs within APSA are important. So I think this will always be there. I think we'll always still complain about how much it costs, but I think it's an integral part of evolution of any profession.
Thanks again.
Thank you.
Yeah, that's right.